said something in the chat box. Okay, so I want to keep this fun and interactive, and just yell out if you guys have any questions or you want me to stop. But this is going to kind of focus on mitral valve disease and imaging, and I wanted to put some slides in here for aortic valve disease. But if we have time at the end, I want to show you guys a couple of echoes, and I know I've asked several of you to repeat some of these imaging studies with DEFINITY for aortic valve disease and for gradients specifically. So I'll touch about why we do that and what I'm kind of looking for and why it's so important to use DEFINITY, and kind of when I want you guys to think about that, so you don't have to get one of those dreaded texts from me asking you to do more images or do another limited study. But I do appreciate you all putting up with that. So let's see here. Okay. Close this. All right. So we have, and Aaron, do you have a full head count down there?
Yeah, people are coming in and out, get something, but yeah, we got a good amount of people.
Okay, and then there's some more folks on the phone as well. I don't know if you are on the phone and you need credits for this talk, just let me know. If you're not there in person and Aaron hasn't written your name down, we can get you guys some credits. I know Kane.
If they can put their name in the chat box, then we can get everybody.
Oh yeah, well, some people are just logged in on the phone as well. But yeah, if you guys know how to use the chat box, just put your just put something out there in the chat box, or just let Janie or myself know. So this talk is, as I mentioned, centered around the mitral valve. We're going to talk about the significance of mitral regurgitation, why it's so important, and looking for it at least in echoes. And we'll talk about the anatomy of the mitral valve. Welcome, Jamie. We're just getting started, so perfect timing. We'll talk a little bit about the anatomy of the mitral valve and go over some of the basic echo views, a little bit more in detail though, because you can actually tell quite a bit from just a transthoracic echo alone. You don't need a TEE for a lot. It just depends on kind of the images that and the views that you guys are able to obtain. And if you, some cases actually, I don't obtain a TEE on just because the transthoracic is so perfect and it looks so pathognomonic for severe MR. I already know what I'm dealing with. We'll show a quick video of the mitral clip procedure. I'll show you some case studies from early on in our experience here, and we've done some really neat ones lately. I know Oscar's putting those together, so maybe we'll come back and touch base with you guys here in another month or two with some of the other cases that we have. And then I'll talk specifically about how to assess for mitral valve pathology and transthoracic echo. So now we'll talk about the significance and types of mitral regurgitation. So mitral regurgitation is actually the most common valvular heart disease, more so than aortic regurgitation or aortic valve disease, including aortic stenosis. Even though we talk about aortic stenosis a lot, we have thought about it historically a lot, mitral valve disease is much more common. And that's by several fold in prevalence. And especially as we get older, most folks have some degree of mitral valve disease. And if you have severe MR, it actually increases your mortality and your heart failure readmission rate. Now, the reason that MR is so deadly is that we don't have great pathognomonic criteria for assessing it on transthoracic echo. So just, for aortic stenosis, you can see that there's a crunchy aortic valve that will kind of clue you in to say, okay, these aortic valve leaflets aren't opening properly. With MR, we don't have that. What we have is just, sometimes if you catch, you can have a very, very severe patient with very, very MR, with a very large amount of mitral regurgitation. But the problem is we miss it. And because we miss the jet, we don't capture, we're a little bit off axis, and then it looks like it's maybe mild or moderate. And that may be the only clue that we have to clue us in that this patient with an EF of 25 to 30% has significant severe functional mitral regurgitation. But what we do know is that these patients who are untreated don't do well. And their survival, 5-year survival, I mean, this rivals cancer. This is why heart failure is such a deadly disease. And when I first came here, I was actually making a lot of phone calls to patients who had been diagnosed with severe MR. And I'd say almost half of them, within 6 months of their last echo, had passed away, unfortunately. I spoke with a lot of spouses who were just tore up that, you know, their mom or their dad or their husband or wife had just passed away with heart failure and severe MR. And on top of that, it also leads to higher heart failure readmission rate, on 80% higher readmission rate. So significant. I mean, we're talking quite a bit here. This is data that's already out of date. It's about 10 years old, but the number of people that have severe MR that are walking around is who ultimately get treated is very, very little. And this is, even though it's outdated, it's still quite relevant because we've got over probably at this point 6 million patients with mitral valve disease, and probably over 2 or 3 million of those patients are eligible for some kind of therapy, whether that's with surgery or mitral clip. And so because of these, you know, and it's not that, you know, we don't send these patients for therapy. I mean, most of them do get sent on for therapy when they're diagnosed, but the key is, and that's why it's, you guys are really our first line, and this is something that Aaron will talk to you about, but you're the most important part of the team. Because if you guys don't see it, or you guys don't find the MR, we can't see it. You know, we can only see what you guys show us. So that's why I wanted to spend a lot of time talking with all of you and getting you comfortable with this pathology, and also getting you to think a little bit outside of what the protocol is. I mean, we want you to stick to the protocol, but there's no harm in taking extra pictures. If you see something that looks interesting in the echo, spend some time and investigate it a little bit and show us, tell us a story. You know, tell, when I say us, I mean whoever's reading that echo, whatever cardiologist that you have assigned to read that echo, tell a story. I mean, if you want to show something, if you want to demonstrate, for instance, on the left-hand side, you'll see, can you guys see the moving image there of the bileaflet prolapse?
Yeah.
Okay, and someone's typing in the background. If you guys are not, if you're typing or doing something else, please just mute if you don't mind. But you see that bileaflet prolapse there. That, you know, if you see that on an echo, that should kind of clue you in to say, hey, that's not normal, right? That doesn't necessarily mean this patient needs something done. They may not have any MR, and that's, you know, but it is definitely an abnormal finding. So same thing here on the right. You've got a ventricle that's very dilated. It's, you know, clearly not a healthy ventricle, but here the leaflets are kind of being pulled apart. And so that's leaflet tethering, and that's classic for secondary or functional MR. So what we, I mean, and that's how we classify these two different types of MR. One is primary on the left, where the valve is really the problem. Here you see the ventricles moving just fine. And here the second one is the valve is fine, but the problem is the ventricle is not moving well. So so here are the different types of primary MR, at least, you know, so these are kind of mixing transthoracic and transesophageal echoes, but this is where you have a posterior leaflet problem. So can you guys tell what the issue is here? Just call it out.
Prolapse of, oh no.
Yeah, I don't know what it is either, but it's prolapse of the posterior leaflet, right? Good. So, and here it's the same thing, but no, it's on the anterior leaflet. What about on the bottom here? This is a transthoracic here on the bottom right. If you're on the phone, just yell it out if you can.
Bottom right.
Or if you're not in that room, just unmute yourself. Make sure you unmute yourself if you're trying to talk.
Prolapse of anterior?
Yeah.
No. Yeah. Oh, okay.
So, and then the bottom left is what we call a flail leaflet. And this is the posterior leaflet on a transesophageal echo, and it's flail, meaning it's coming above the line of coaptation. And this is, you know, definitely going to cause severe MR. So mitral valve anatomy. So the mitral valve has two leaflets. There's an anterior leaflet, which is usually larger. It's in fibrous continuity with the aortic valve. It occupies 1/3 of the circumference, but it's larger, longer, and thicker. And it has 3 scallops, the A1, A2, and A3. And the way we just kind of refer to them via convention only is just the A1 is on the lateral side, so that's the side closest to the circumflex and the left atrial appendage, if you're looking at it on transesophageal echo. And A3 is the medial side, so that's the side that's away from all those structures. So, and the way I just remember that is A3 is like this, 3 is like this, and then if you flip it over, it becomes an M. Stupid pet tricks, I'm full of them. So and same thing with 1 is 1, and then it becomes, it looks like an L almost, 1 lateral, get it? So that's how you kind of can keep those things straight in your head. And so it's very important that you get familiar with the nomenclature, though, because it is important to know where on the valve you are. And this is a very simplistic kind of overview, this A1, A2, A3 concept, because if you look at some patients' valves, they oftentimes have more than 3 scallops. Sometimes they have 4 or 5. I mean, so, but it just kind of gets you in the habit of really discussing when you're talking to your colleagues about an A2 flail or an A3 flail, especially with a therapy like MitraClip, where it really matters where you are on the valve. That's kind of the purpose of having these discussions. So the posterior leaflet is crescenteric shaped. It has 2 indentations which kind of delineate the lateral and medial and central portions. And same thing, it's P1, P2, and P3. It's takes up 2/3 of the circumference of the actual annulus, but it's a shorter leaflet overall. And this is kind of what that looks like. So you see the posterior leaflet makes up much more of the circumference versus the anterior leaflet, but it's a much shorter leaflet. Same thing here. This is what we call the surgeon's view. So, and this is a 3D TEE image. So for those of you who are not doing TEE routinely, this is the lateral side. So remember 1 is the L. So that's the L over here on the left. And then 3 here is medial, and that's on the right. So this is where you'd see maybe you can even see the left atrial appendage on this side. The left upper pulmonary vein is on that side as well. So this next video will just quickly review the procedure, the MitraClip procedure. You guys are always welcome to come up. We usually do these on Thursdays and just watch in the cath lab if you're interested. But this kind of provides a quick overview of the actual procedure.
MitraClip is a unique, highly maneuverable transcatheter system for mitral valve repair. This procedure avoids cardiopulmonary bypass using minimally invasive venous approach.
Oh, shoot. We'll start that over. Sorry, I just want to.
Transcatheter system for mitral valve repair. This procedure avoids cardio.
Can you guys hear the audio in that clip? Is it coming through?
Yes.
Okay, great.
MitraClip is a unique, highly maneuverable transcatheter system for mitral valve repair. This procedure avoids cardiopulmonary bypass using minimally invasive venous approach and transseptal puncture to gain access to the left atrium. MitraClip's steerable guide catheter is introduced over a previously placed guide wire. The dilator is used to gradually advance the guide into the left atrium, and the guide wire and dilator removed. The clip delivery system is advanced into the left atrium, positioning the clip above the regurgitant jet and perpendicular to the mitral valve plane. Inside the left atrium, the clip arms are open to 180 degrees and positioned perpendicular to the line of coaptation before crossing into the left ventricle. The clip is advanced into the left ventricle below the valve leaflets and retracted to grasp the leaflets. MitraClip grippers are designed to drop firmly into the clip arms, securely capturing both leaflets. Once the arms are closed, they create a double orifice within the mitral valve. Prior to clip deployment, echocardiographic imaging is used to assess procedural efficiency and leaflet capture. Prior to deployment, the MitraClip can be released and repositioned for optimal MR reduction. Once achieved, the clip is released and the full system retracted. In most cases, the transseptal puncture reseals itself and tissue ingrowth between the clip arms increases, facilitated by the polyester clip covering, which promotes healing to create a fibrous tissue bridge between the leaflets.
Okay, great. Any questions about that more about how we do the clip procedure or anything?
No, sir.
No.
Okay,
No,
so
sir.
the mitral clip does work, and it works very well. Now we actually have 3-year data that shows that the mitral clip continues to save lives out past 3 years in patients who have severe MR and who are randomized to the device group. And what's interesting is that even what they did was in this trial, they actually had a crossover randomization group. So the patients who did not get mitral clip initially were randomized to the mitral clip group about at month 12. And even if you're randomized at this point, it still saves your life to go ahead and get a mitral clip. So that's very powerful data. And it's a very safe procedure, less than 5% complication rate. And we've had good success here with it as well. So what does it look like when it's not on YouTube? And so these are all images from Dr. Panati and the OR. So here's our transeptal puncture, and that's us literally creating a hole in the interatrial septum. And then the next picture here is crossing with the 24 French guide into, we're going from the right atrium to the left atrium. So here we're orienting the clip. And so here, this is the clip arms. This is the anterior leaflet of the mitral valve, posterior leaflet of the mitral valve. And here's the clip arms. And these are the grippers kind of coming down. So what we're doing is we're creating a sandwich, because here are the arms. And then what we'd like to do is put the leaflets on top of the arms and then put the gripper down on top of that. So now the leaflet can't go anywhere. And then we're able to close the arm. So it's literally a leaflet sandwich. So let's look at some cases. So I have 2 cases, one that's degenerative MR and one that's functional MR. So this is an 83-year-old gentleman who's still doing really well. He told me he was a Domino's Pizza delivery driver. I don't think that's actually true, but I believed it. So anyway, he's definitely a big jokester, but he's a funny guy, and he's been living with severe degenerative mitral regurgitation or primary mitral regurgitation for a long time. And here's why. So you can see, can you guys tell what his anatomy is? What's wrong with this valve? Obviously, it's a very leaky valve, but what's the pathology here based on what you're seeing? So
Anterior.
What's that?
Prolapse. Anterior prolapse.
Yeah, but it's more than just a prolapse, right? So you see this, you can see the
Flail.
anterior leaflet here. Yeah, it's a flail. So that's, and this is the difference between a prolapse and a flail, because a flail most always will cause severe MR. A prolapse not always will be related to severe MR. It just depends on how bad it is. So the goal with this is to basically clip this portion of the diseased leaflets together. And that's exactly what we did. We actually ended up putting 2 clips in, right where the issue was, and this guy ended up having almost no MR the next day. The next patient is a 65-year-old gentleman with severe functional MR, low EF. He's already had CABG once, had 3 hospitalizations for heart failure in the previous 6 months, and you can see his heart really is not working well. So again, this is an issue where the leaflets itself, we're not seeing that aggressive flail leaflet or anything here. So what's happening here is the ventricle's dilating, and the leaflets are just simply getting further apart from each other. So now you have this valve, which is just super leaky. And so we put, these usually require more than 1 clip. And so we ended up placing a couple clips, and we move them around just depending on where we want to go on the valve and where the pathology is and where the leak is. But we ended up putting in 2 clips. And so this is the pre and post-op TTE. So he's still, these are never going to look perfect. These degenerative MR patients are always going to have some degree of mitral regurgitation left. It's very rare for them to look like the last guy. But this is a fairly good result. So, and I think Dr. Panati's already talked to you guys about how to really interpret post-mitral valve clipping, what to look for, because a lot of the usual things are not very helpful, as always, because sometimes we'll see what looks like a lot of MR, but the patients are feeling a lot better. And what's interesting is that we'll leave the lab and we have a completely different result on transesophageal imaging. So it's just once these clips are in, they create a lot of shadowing that can make things difficult. So this is the most important part of the presentation, and that's why I wanted to spend a little bit more time on this. These are tips for screening for severe MR on transthoracic echo. And I'm recording this as we talk. I should be recording. Yeah, looks like it's on. So what I'm going to do is actually make this available for you all after the presentation so you can go back and watch it. But these are the things that I really want you to take away from this. So far we've talked about the significance of mitral regurgitation, so you know it's a bad disease. It kills people. It puts people back in the hospital. We've looked at the anatomy of the mitral valve. We've looked at different, meaning the anterior and posterior leaflets. We've looked at case studies, and now we're going to look at how you can really interrogate a mitral valve, especially on transthoracic echo, because you all do transthoracic echo. So the valve anatomy, so there's various things that you can look for on transthoracic echo. So let's look for just the valve anatomy alone. So if you just zero in on the valve, if you see that prolapse or that flail on transthoracic echo, that is a big clue, and you need to look a little bit closer. If you see a low EF, always be thinking about severe MR. That doesn't necessarily mean most patients with the low EF will not have severe MR, but the ones that do, just remember, if you find it, you can make a huge difference in that patient's life. You can save somebody's life because we can actually do the MitraClip if they're a candidate, and that in and of itself will add several years to their life, as we know from these randomized trials. If you see rheumatic changes with a loss of central coaptation, or if they've got a history of endocarditis, or any kind of valvular disease or history of valvular disease, just be on the lookout for that. And of course, if you see thickening of the leaflets, all of that is not normal. So the hemodynamics are also very helpful here. You guys already are familiar with most of this, but if you have a central jet that's greater than 40% of the left atrium, or an eccentric jets are usually never benign, and they're usually never mild. They're most, my rule is, if it's an eccentric jet, I have to prove that it's not severe MR. It's like, guilty until proven innocent, essentially, if you're an eccentric jet. And that may not be fair to eccentric jets, but that's what happens, because when you have that wall-hugging or coanda jet, I was always taught that that was basically, again, severe until proven otherwise, because that suggests that there's something going on, especially if it's truly wall-hugging. And those are dangerous because you may not see the change in the flow in pulmonary veins, because you have to look at the exact pulmonary vein that flow or that regurgitant flow is going towards. If you have a large vena contracta, of course, like we saw in the second case study I showed, that is a sign for severe MR. A high regurgitant volume, or EROA, and we're going to go over those in a little bit more detail so you can really understand what those things mean. I think we toss those words around a lot, but we don't take the time to understand when you're actually doing the measurements what creates a higher EROA or regurgitant volume. If you're E-wave dominant, if you have a lot of early flow, that suggests, and what that means is that you have a high left atrial pressure. So that's suggestive of any condition that would cause a high left atrial pressure, like severe MR. It could also be MS, because you have a high left atrial pressure in that condition as well. And what you're seeing is that E-wave is kind of the first hump of the double mountain when you're looking at diastole. And that E-wave, if it's dominant, and if it's very dominant, and there's very little A-wave, that means that most of the left ventricle is filling very early just due to that pressure gradient. Now, that's not always going to be the case, because sometimes you can have patients who have had an MR for a long period of time, and they almost have equalization of pressures because they're so volume overloaded. So these are all just clues to a bigger story, and you got to look for that story, and that's why you always have to be constantly vigilant, because if you miss it or you don't think about it, you won't see it, because that's why this is so much more difficult to diagnose than aortic stenosis, and that's why it's so much easier to talk about aortic stenosis, because there's really just one thing to look at. You look at the aortic valve, you look at the gradients, and if the gradients meet criteria, you have aortic stenosis. Pretty simple, for the most part. Here, obviously, this whole slide kind of tells the story that it's much more complicated. Structural changes are also important. If you are calling something severe MR, there should be some left atrial dilation that goes along with it. Now, I see a lot of echoes where you guys are measuring the left atrium. And one thing that I see a lot of is that you actually measure it in a apical four-chamber view, and it looks like it's normal, at least by left atrial volume index, it measures that to be normal. But then suddenly you go to the subcostal view and you put your probe down. I don't know how many of you are actually looking for this, but if you look at the left atrial size there, sometimes the left atrium is twice as big as the ventricle, both ventricles. And in that case, that tells me that, well, this patient probably has more severe left atrial enlargement than we realize. So again, I think, and I was always taught with diastology that if you can't have abnormal diastolic function without an enlarged left atrium. So just another thing to kind of think and keep in the back of your head. And obviously, there's no, that's the tricky part about echo, and that's the beauty of what you guys do every day, is that every study is different, every patient is different. So you really have to be on the lookout for all of these. LV enlargement can be seen, but again, it's not always seen because it depends on how early you find the MR. And pulmonary hypertension or elevated RVSP will be another issue. So obviously here, you see the issue here. You can see that there's a flail anterior leaflet. They've used color compare here. So, but the questions that you want to ask is, don't just focus on the color, because our eyes always just go to the color. But look at this 2D black and white image without any color and say, first of all, before you even turn the color on, you should already know what this is going to look like this, because you see this anterior leaflet, it's flail, and there's a cord that's kind of flopping in the wind, so you know that there's going to be a jet that's directed that's going to just come right out of this hole here, and it's going to come and hug the wall here, and that's exactly what's happening. Right, so if you can predict what's going to happen when you turn the color on, that's very powerful, because then that'll help you tell that story. So this is a perfect example of, I really don't need a transesophageal echo. Of course, we're not seeing all the details here, but I know that this is a leaky valve, and this is one that, either needs surgery or a mitral clip. So for me personally, I can't speak for the heart surgeons here, but I can say that I don't need a transesophageal echo in this case. So the peristernal long axis view is the view that I personally think we can make about 70% of our diagnosis on. This really does show A2, P2 very nicely. It will show you malcoaptation of the leaflets. You can measure the vena contracta. You get a sense of the chordae and the valve, and of course the ventricle. You can check to make sure that the ventricle is not fully dilated. You can get a rough idea of the EF, etc. So if you don't see a lot of MR here, remember you're at a basic almost perpendicular in this peristernal long axis view. Your cosine of theta is not going to be very favorable to picking up color flow, because blood flows is moving this way and your probe is trying to measure this way. So keep that in mind. And if you do see a lot of MR here, what I teach people is that if you see a lot of MR, you have severe MR. Because despite overcoming this cosine of theta issue, you still have a lot of leak, then that means that this valve is very leaky. So kind of breaking this down, what I see from this echo is that there's no wall motion abnormalities, there's some mild thickening of A2, and there's actually a flail P2 segment. If you look very closely, you can see that. Now, that's easy to miss, and I probably would have missed that too. But that's where it really helps if you guys when you're intentionally scanning, instead of just kind of going through a protocol, like I said, if you see something that looks funny to you, or you start seeing a lot of color, when, let's say you miss this P2 prolapse initially, but then you turn on your color and you're like, there's a lot of color here. There's a lot of MR, there's some degree of MR here, and this valve looks fairly normal, and the ventricle looks normal. So that should get you thinking like, okay, there's something going on here. So go ahead and zoom in and look at what happens to your frame rate here. When you zoom in, it goes from 55 to 162. And then you add color. Your frame rate goes down, but it's actually much higher than your frame rate would have been if you added color to this big image. So these little tips and tricks that you guys all know already makes a big difference in being able to appreciate this. So now look, suddenly when you zoom in, now it's a lot more clear that something's happening, and we're maybe a little bit out of plane, so we'll be able to look for it later on in the study. and suddenly look, now we've got a lot of color. So there are a lot of opportunities when you're doing your exam to really go through and think about what it is that you're seeing and how you can show it differently. Assessing vena contracta is best assessed actually in that parasternal long axis view. Really try not to do it in any of the apical views, especially the apical two-chamber view. And try to move your focus knob and minimize your depth and sector width to focus on the valve, and always make sure your Nyquist is set to 50 to 60. So if you're seeing a lot of color, that's the first thing. Your eyes should always go here, and just make sure that your baseline's appropriate and your Nyquist is set appropriately. And just a reminder, here's your vena contracta here. It's just at the leaflet tips, you're measuring the jet of turbulent flow, the width of that. And this is your jet area, actually. So that's where that 40% of left atrial jet area, that's what criteria comes into play. And that's more of just an eyeball thing. There's really not, but you can clearly tell that that particular jet in this echo is clearly over 40%. Now, I really like this view, this parasternal short axis view, and I really encourage you guys to take more clips of this, especially if you can get to a point where you're seeing the leaflet tips on the short axis view, because this tells you exactly how wide across your jet is. Is it just in the middle of the valve? Is it the entire length of the valve? And that also gives me a clue as to the severity of the valve. And it also allows us to get a better idea of the pathology. Again, we can also, it can guide us into determining whether something's a posterior prolapse or flail, etc. And here's that planimetry. We can actually do a decent planimetry based on just the short axis mitral valve area alone. So the apical four-chamber here, you know, like this is the exact same echo we saw 2 or 3 slides ago in that short axis, that parasternal long axis view. And now you can see that posterior prolapse or flail or whatever was going on here. Now we actually see this flail portion of the leaflet. So this explains why we see that large eccentric jet. But hopefully we picked up on this before we even get to this apical four-chamber view. So this is very important for a lot of things. This is kind of a workhorse view. We're going to be assessing the size of the left atrium, the size and function of the left ventricle. This is where we quantify the MR by PISA and EROA, and where we can obtain diastolic gradients and pressure half-time. So again, you know, always stop and think when you are looking at just the view without putting color on. See what the pathology is. See, obviously, you've got, you know, put the pieces of the puzzle together. You've got this left atrium that's big. It's bowing the septum over on the interatrial side towards the right atrium. So clearly, whatever's happening here is bad because there's more pressure here than there is in the right atrium. And you expect to see a large eccentric jet, which is what we'll see. So the jet area is the least reliable, and again, that's because of all the loading factors and what the patient's intravascular volume status is and whatnot. So that's not something that I spend a lot of time trying to calculate or figure out, and that's really not what I look at. But PISA is very important, and we try to do that as accurately as possible. So the baseline for a PISA should be adjusted in the direction of the regurgitant jet. So it's always going to be towards the left atrium. So that, if you just remember, move the baseline towards the left atrium, that'll serve you for both the transesophageal echo and the transthoracic echo because they're reversed, obviously. The goal Nyquist should be 30 to 40 on that side. And you want to measure the radius from the point of color aliasing to the ventricular aspect, and I'll show you what that looks like. For functional mitral regurgitation, the PISA is not perfect. It may not be one, and we may still take a patient for a mitral clip. And that's because if you have a broad-based jet, you have leak from all across the valve. The PISA, it doesn't really matter what the PISA is because that valve is very leaky all across. So in this particular case, you measure from the plane of the valve up to the ventricular aspect. So this would be my PISA here. And this is just demonstrating that jet area. And here's that PISA a little bit more detail. So here they're measuring it at 0.8. So what we're trying to do when we look at PISA, that's proximal isovelocity surface area. That's a mouthful, but here's what we're trying to calculate essentially. So we're trying to determine the effective regurgitant orifice area, the regurgitant volume, and the regurgitant flow rate. So the regurgitant flow is determined by 2 pi r squared. Okay, so that is the calculation for a sphere, I believe. Pi r squared is the area of the circle. And if you multiply it by, it's almost a calculation for a sphere. I think that's 4/3 pi r squared. Anyway, you multiply that by the velocity, VA. And so and that's the velocity from here. That's why that number is important, okay? So the flow rate in this particular patient here, we're just doing the math here, is 118 cc's per second. That in and of itself doesn't really tell me a whole lot. But then you plug that number in to the EROA calculator, which is the regurgitant flow, which is what we just found, in 1 second, divided by the peak velocity of the regurgitant jet. So that's 400 in this case. So this is where that MR-VTI number that you get from tracing this, that's where that comes into play. So this is really important, and I'll ask you guys this question. You can pause and think about it. But if you have a patient with severe MR, is this number going to tend to be higher or lower? Or is this, when you do your continuous wave Doppler, are you expecting it to be really, really high or really low with severe MR?
Low and then lower,
Yeah.
like.
Yeah, so why is that? Can you explain that to the group, Des?
I mean, I can try. I would think, like, just the pressure equalizing maybe. I mean, that's what happens whenever you have, like, severe TR and you, like, eventually the pressure is equalized and you have, like a triangle-shaped jet, but, like, not as high a velocity, but very thick waveform.
Yeah, it's all about the velocity of flow, right? Because this is the flow going backwards. So that's good. Thank you. It's all about the velocity of flow going backwards. So it's kind of similar to a VSD. So if you have a very small VSD, it's going to be very loud, and it's going to have a high velocity jet because it's similar to aortic stenosis. Same thing. If you have a very small hole, you expect to see a much higher velocity when you're measuring gradients and flow across the aortic valve because you're squeezing a same amount of blood through a much smaller orifice, right? So but with a small hole in aortic, the smaller the hole is for aortic stenosis, the worse off the patient is. Here, the smaller the hole is for MR, the better off the patient is because that means that you don't have as much regurgitant flow. So what you're really measuring there is, how we're really just trying to understand how much blood is flowing backwards, but we can't directly measure that. But these are kind of all the methods we can use to try to calculate our way around it and it's very beautiful how, how much you can really tell from just sound waves. If you think about it, like what you guys do is so cool, just because you can determine so much information and get so much data just from a simple test that really has no risk to the patient and very little cost. I mean, just in terms of, we're not having to those machines we use over and over and over, right? So it's very cool how much we can tell. So, and you can do this test again and again and again, and it's not like a CAT scan where the patients are getting this innumerable amount of radiation. So the lower the velocity here, the more that's just like having a big open spigot or a hose with a really big opening. The water is not necessarily going to rush out of there, but there's a lot of water, a lot of volume can come out of there. It's just like when if you put your finger over a garden hose, for instance, the smaller you make that hole, the higher velocity that water is coming out of the end of that garden hose. Versus if you just take your finger off, you're going to get a lot more water to come out, but it's going to be at a much lower velocity. That's probably the best way I can explain it. So does that make sense to everyone?
Yes.
Okay, perfect. Yeah, so the regurgitant volume, that's where you use that VTI calculation. And while we have this beautiful continuous wave Doppler up, I really like this view as well. And because this also gives you another set of information, because, and Desiree alluded to it when she said, well, this is how you should tell how dense the jet is. And also it gives you the timing of the MR. Because if it's, you only see really dense MR, but it's only in the early part of systole, and then everything else is just blank, it's just black, that means you have early systolic MR, and that's really not severe MR. You know, we want to see holosystolic MR, and it needs to be dense throughout. So that tells me a lot too. So these are all just little pieces to a very complex puzzle that you guys are putting together as you do these studies. And pressure half-time is the mean diastolic gradient, and the mean diastolic gradient, this is basically how how the computer measures it. But essentially, we like to take several of these and doing it pre-imaging, or during it, like if you see severe MR and you measure pressure half-time and a mean gradient, it's helpful because the mean gradient may be 4 in this case, right? And the patient has severe MR, but is it really because there's mitral stenosis here? It's probably not. It's actually probably due to the volume of flow. So that's where this pressure half-time, and you see how steep this slope is. This is a patient that just has severe MR and doesn't really have any issues with mitral stenosis. Now this patient has a mean gradient. I don't know what it says here. I think I may be covering it up. Anyway, the mean gradient, I believe, is around the same 4, but now look at the pressure half-time. It's much more gradual, which suggests that this is true mitral stenosis up here. And the patient may have MR as well. So that makes a big difference. Pulmonary veins, they're very, very difficult to tell. I've only seen a few really non-noisy pulmonary vein studies, and that's just a limitation of transthoracic echo, because look how far what you're trying to measure is from your probe. I mean, that's the problem with pulmonary veins. And the nice thing about transesophageal echo is that it's flipped. But I put a lot of stock in the pulmonary veins. The pulmonary veins are reversed. That's what was a guideline indication, or what is considered one of the criteria for enrollment in these MitraClip trials. So that to me means a lot. And same thing when we're in the middle of our procedure, they changed instantaneously. As soon as we apply clips on, the pulmonary veins will change. So they can normalize, and that's when we know we're done. Even if the color still looks like it's pretty terrible, if the pulmonary vein flow normalizes and we started with reverse pulmonary veins, then we're done. We're not doing anything else to this valve. So again, the 2-chamber view is helpful as well. It helps us assess the width of the jet along commissural lines and the pathology of the jet. And it's very similar to what we call the bicommissural view on transesophageal echo. So you can see the medial part of P3, the lateral part of the valve, the leaflet P1, and a flail P2 entering the left atrium. So it's a little bit different, of course, because you're not seeing the anterior leaflet here in the bicom, which you normally see in the bicommissural view. But this view is actually quite powerful, and it's one that I have to continuously remind myself of what parts of the valve that I'm seeing as well, because I forget as well. But it is very useful. More so not because of the color, but more so because of what you can see pathology-wise. So putting it all together, so we've got this peristernal long axis A2, P2 pathology, the short axis of planimetry, apical 4-chamber. We talked a lot about PISA. We talked about EROA, apical 2-chamber as well. More so about the pathology of the actual valve, and less so, we're less focused on color there. So we talked about how to assess mitral valve pathology on transthoracic echo. I've shown some procedure examples. We've talked about the basic anatomy and the importance of diagnosing MR. So I love this quote from Steve Jobs: "Technology is nothing, but what's important is that you have a faith in people, that they're basically good and smart, and if you give them tools, they'll do wonderful things with them." And that describes so much of what we do in medicine today. So I'll let you guys